Good morning, respected judges. The title of my study is Bone Microarchitecture, Bone Mineral Density and Vertebral Fractures in Primary Hyperparathyroidism, a prospective cohort study. Primary hyperparathyroidism is a disease which is known to preferentially involve cortical bone. However, previous studies have shown an increased prevalence of vertebral fractures as well. So the key points which are addressed by our research is what happens to the overall bone microarchitecture in PHPT, what is the difference in the pattern of involvement of bone mineral density and bone microarchitecture, what is the pattern of recovery of BMD and bone microarchitecture after parathyroidectomy, to what extent is vertebral bone affected and what are the factors contributing to its involvement, and can preoperative bisphosphonate use influence the BMD and bone microarchitecture and its recovery in PHPT. The aim of our study was to assess the bone microarchitecture and analyze its recovery after parathyroidectomy in PHPT patients. Objectives were to assess the BMD and trabecular bone score in patients with PHPT at baseline and at 6 and 12 months, that is 1 year after parathyroidectomy, and compare with that in healthy controls, and to assess the prevalence of vertebral fractures in PHPT and compare with that in healthy controls. 120 patients with hyperpara and 80 healthy controls were recruited for our study. Number of patients who completed follow-up at 6 and 12 months were 50. Healthy controls were not followed up. All patients and healthy controls underwent assessment of biochemical parameters, BMD and TBS. BMD was measured using DEXA hologic machine. A vertebral fracture was assessed using vertebral morphometry on the same DEXA machine, and trabecular bone score was assessed using TBS Insight software installed in the same DEXA machine. The least significant change was calculated, which was 2.3% for lumbar spine, 5.7% for the femoral neck, 4.3% for the total hip, 2.4% for the distal radius, and 6.12% for the TBS. Now coming to the results, the patients and healthy controls were age and sex matched. The mean serum calcium was 12.1 milligram per dl in PHPT compared to 9.1 in healthy controls. The mean serum phosphorus was 2.6 milligram versus 3.6 milligram per dl in healthy controls. The median serum alkaline phosphatase was 364.5 international unit per liter versus 240.5 in PHPT versus healthy controls. The vitamin D level, the mean 25-hydroxy-D was 18 nanogram per ml per dl versus 13.8 nanogram per dl, and serum IPTH was 263.1 picogram per ml versus 48 picogram per ml. Now coming to the densitometric parameters, all patients with hyperpara had significantly lower BMD at all sites compared to that in healthy controls, and they also had significantly lower TBS compared to that in healthy controls. The mean TBS in PHPT was 1.251 plus minus 0.124, whereas that in healthy controls was 1.323 plus minus 0.103. Both TBS adjusted and unadjusted fracs were also higher in the PHPT group compared to that in healthy controls. Now, if we classify the PHPT into three categories, majority of the patients, that is 47%, had TBS score in between 1.21 and 1.34, suggestive of partially degraded microarchitecture, while 34% had 47% had partially degraded microarchitecture, where 34% had fully degraded microarchitecture. The prevalence of vertebral fracture in PHPT was 46.7% versus only 2.5% in healthy controls. Majority had biconcave fractures and majority had grade 2 vertebral fractures. These are some of the radiographs highlighting the vertebral fractures in PHPT patients. Patients with vertebral fractures were older, they had a longer duration of symptoms, they had higher serum alkaline phosphatase, they had higher serum intact PTH levels, they also had lower BMD at all sites, and they also had lower TBS compared to those without vertebral fracture. Also, the TBS adjusted and unadjusted fracs were also higher in the group with vertebral fractures. Now coming to the follow-up data, the percentage change in BMD and TBS from baseline, patients who underwent parathyroidectomy showed significant change in lumbar spine BMD, femoral neck BMD, total hip BMD, but there was no significant change in distal radius BMD and TBS even after 1 year of parathyroidectomy, and it did not exceed the least significant change. This is the graph showing the pattern of recovery of BMD and TBS at 6 and 12 months. Now last point is in patients who had preoperative bisphosphonate use, this group showed significant improvement in lumbar spine, femoral neck and total hip BMD, but the change in distal radius and TBS was again not significant. So these are some of the graphs showing lumbar spine BMD and TBS percentage change from baseline in patients with and without bisphosphonate use. Again, the graphs are showing the changes in femoral neck, total hip, and distal radius BMD changes. The blue one represents patients who had bisphosphonate and the red one who did not have bisphosphonate. So the conclusion of our study is patients with PHPT have significantly poor bone microarchitecture reflected by lower TBS compared to that in healthy controls. Following parathyroidectomy, significant improvement were observed in lumbar spine, femoral neck, and total hip BMD, but no significant change in distal radius BMD and trabecular bone score up to 1 year. BMD gain at lumbar spine, femoral neck, and total hip were significantly higher in patients with preoperative bisphosphonate use. Prevalence of vertebral fractures in PHPT was significantly higher than that in healthy controls. Thank you. Yes, sir. This was my DM thesis. It was done over a period of 3 years. Sorry? Yes, 120 hyperpara patients and 80 healthy controls.
During the follow-up, nobody developed a new vertebral fracture, both your controls and your patients with PHPT, because the average age was 67.
Yes, sir.
So in over a year, you would have expected at least a couple of new vertebral fractures.
Actually, sir, it did develop, but we didn't include that data. We did not look for incident vertebral fractures were followed. Our primary focus was on recovery of BMD and trabecular bone score.
So even the controls you did not follow up for?
Controls were not followed up, so because of difficulty in recruiting controls and because of difficulty in following up the controls. Controls were the relatives of, the nursing officers and all the staff at All India Institutes. Sorry?
Controls were age and gender matched?
Yes, controls were age and gender matched.
Can you explain the lack of improvement in parameters at the distal radius?
Actually, I went through the literature, but as such, even the literature also says that it has not been clearly explained why the cortical bone takes such a long time for recovery. Even Silverberg et al. And all, Bilzikian, they have done studies up to around 10 years, but still there was not significant improvement in the distal radius spine. One thing that can be explained is that bone remodeling process is a bit more in trabecular bone compared to that in cortical bone. So there might be, it might take a longer time for recovery, which might not be assessed, only during very long-term follow-up studies. And similarly, trabecular bone score also did not show any significant recovery, even following up after 1 year of parathyroidectomy.
Can you name some conditions where there is significant change in BMD following therapy or following in some intervention like this? Like you showed in 6 months, 12 months. We generally don't expect, no?
So,
change in bone mineral density. Do
Yes.
we expect such increase in bone mineral density? This is one condition. Can you say more?
Osteoporosis, even other conditions of hyperthyroidism, secondary causes of osteoporosis like hyperthyroidism, then primary hyperparathyroidism, and
Thank you.